have our luckily we have our chairperson of the Heart Failure Scientific Council of PCS with us. So I have asked him to give brief introduction or brief comments in this webinar. Dr. Shahbaz Qureshi is with us as our panelist. Dr. Shahbaz, Dr. Shahbaz,
तो आधे हैं
जी हाँ।
Dr. Shahbaz, we are displaying your
आपको मेरी
slides.
आवाज आ रही है?
Are you? हाँ
अब आ रही है
अच्छा,
पर
ठीक
डॉक्टर शहबाज शक्ल आधी है हाफ फेस ऑन दी वन शोल्डर
है। उसके करना करें।
So are you? Your slides are ready?
मुझे 1 मिनट दे दो, मैं तो डॉक्टर साहब का वो खोल लूं जरा। अच्छा, बिस्मिल्लाह। क्या आप मुझे देख रहे हैं?
जी 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 वी कैन सी यू अब ठीक है
You hear me?
जी जी यस
Yes, please.
Okay. I think Bismillahirrahmanirrahim. Professor Azhar Farooqi Saab, Assalamu alaikum. And, I'm really grateful to Dr. Khalida Soomro for giving me this opportunity to introduce the subject, which is very important. Heart failure in women, and there are a number of sex differences which I would enumerate and explain to you. I will tell you when you have to change my slides, Khalida. Don't hurry up my slides. Basically, when we are talking about heart failure in women, it's a very important subject because there are differences there. And there are gaps in the knowledge also, and we need to identify them and talk about them. And there are going to be a number of subjects which are going to be addressed in this webinar on this very important subject. The overall, when we look at the lifetime risk of heart failure, it is similar between women and men. However, there are marked differences in the landscape of this condition. This is important. And these are under-recognized. Actually, men, they have more of heart failure with reduced ejection fraction, and women have heart failure with preserved ejection fraction. Then in the course of their life, some of them develop breast cancer. As a result of that, the treatment, they also have cardiomyopathies and a reduction in the ejection fraction. And then, as a result of the stress of pregnancy on the cardiovascular system, they can also have peripartal cardiomyopathy. Can you show my next slide? Now, when we look at the different phenotypes, this is a very important slide, and I think this will actually Khalida, my slides are. And then you have the coronary microvascular dysfunction, which is very important, which occurs in women. And there is less of epicardial coronary artery disease. If you look at the risk factor profile that occurs in women, you will see that there is a significant comorbidity burden. More women are obese, they are diabetic, and there is an emotional stress on them. They respond differently to that. There's a vascular stiffness which occurs in women. And as a result, there is a greater concentric LV remodeling which occurs. Then those who undergo treatment for breast cancer with anthracyclines and trastuzumab, the HER2 antagonist, they can result in cardiomyopathy or in chemotherapy, radiation-induced cardiomyopathy, and then you need to treat them. Then you have the hypertensive disorders of pregnancy. In comparison, men have the phenotype of heart failure with reduced ejection fraction. The prognosis in them is a very higher mortality and a better quality of life. And here it is not the microvascular disease which is present, but the macrovascular disease. And as a result of that, there's myocyte and scar formation. You can, because of the macrovascular disease, you have myocardial infarction, which predominates and results in heart failure. You have the patients presenting to a younger age, and there's a higher prevalence of hypertension in men. The obesity promoted development of heart failure with reduced ejection fraction rather than heart failure with preserved ejection fraction. And then the exposure to alcohol and other addictive elements which can result in it. When you look at the different risk factors, diabetes, hypertension, smoking, these affect women in a different way as they affect the men. So there's a difference in that, and that is why there's an epidemiological difference, which I'll show to you now. So from this slide, what we understand is that there are women who have heart failure with preserved ejection fraction, and men have heart failure with reduced ejection fraction. And women have more of microvascular disease, men have more of macrovascular disease. Women in response to this disease have a different outcome as compared to the men. Men with macrovascular disease result in infarction, necrosis, and a reduction in ejection fraction and ischemic cardiomyopathy. Whereas with women, it is more of non-ischemic cardiomyopathy. Can I have the next slide, please? Khalida, can you? Yeah. So when we look at the pathophysiology of heart failure with preserved ejection fraction in women, let us look at the intrinsic sex differences. There are differences. There's a poor diastolic reserve. As I said earlier on, there is a greater arterial stiffness, and as a result, there is more pulse pressure. Then you have a smaller vasculature in women. The vessels are small sized, and there is more microvascular disease. There is more of a concentric ventricular remodeling and a stronger immunity and greater inflammation. Then when we look at the epidemiological factors, there's a higher prevalence of obesity and a stronger relationship with heart failure with preserved ejection fraction and its development. Then in the course of their lifespan, women, they go through menopause, which results in hypertension. There is an impaired endothelial function and an increase in the size of the cardiomyocytes, which I talked about as the concentric ventricular remodeling and fibrosis, and possible role of pregnancy and hypertensive disorders of pregnancy. You see, pregnancy is a stress state which induces stress on the cardiovascular system. And those who have any latent conditions like pre-diabetes, hypertension, they are then manifest as a result of the pregnancy-induced stress. So the phenotypic implications of these intrinsic sex differences and epidemiological factors are a higher LV filling pressure, a lower systolic volume recruitment, and a greater pulsatile afterload. There is more of pulmonary vascular dysfunction and obese heart failure with preserved ejection fraction phenotype. Next slide, Dr. Saber. Now, we know that women are recruited much less in clinical trials. So there are knowledge gaps. There's a limited understanding of pathophysiology for heart failure conditions with gender predominance, like, for example, Takasubos, we talk about that. Then lack of understanding and appreciation of the sex-specific risk factors. There's a lack of data and guidelines on optimal medications and dosage for females, because if you give the same dosage as for men, the effect is more in women than in men because of the prolonged action which takes place in women. The drug stays in the system for a longer period of time. And as a result, there are more adverse actions also in women with these drugs which are prescribed for heart failure. And then there's a paucity of female-specific clinical trial data. We need to recruit more women in the clinical trials, which have not been done in the past. And the reason for that is that most of the time, women come late to the hospitals. They are brought late to the hospitals because of the socio-economic conditions. They do not get the same treatment as the men do, once again, because of the socio-economic treatment and also because of the variation in symptoms. The symptoms of heart diseases, of heart failure are not the same in women as in men. So there are knowledge gaps, and these are the ones which need to be addressed. As a result of these knowledge gaps, you have ramifications, like, for example, when they come late to you, there are greater adverse remodeling, suboptimal risk factor management and primary prevention, a lower quality of life in women, higher rates of medication-related adverse events because of the drug staying in the system for a longer period of time. So all these factors also have, there are large gaps in knowledge. They exist in specific sex-specific mechanisms and risk factors and therapies in heart failure in women. So when we talk about them, we have different phenotypes. Then we have the paucity of clinical data as far as women are concerned. And the treatment which is given to them is still not the same as it is with the men. Next slide, please. So when we talk of the risk factors for peripartal cardiomyopathy, we know that there are environmental factors such as a low selenium level and various infections which have an effect. A pregnancy-associated conditions such as preeclampsia, which can affect the heart and result in peripartal cardiomyopathy. Then there's a genetic predisposition in them. And there's an impairment in the immune system and the autoimmune reactions, and altered cardioprotective signaling, and then oxidative stress. All these are risk factors for the occurrence of peripartal cardiomyopathy in women, and this will be addressed in the subsequent lectures. Next slide. Now, another important aspect is that of breast cancer. And when they are given treatment for that, the chemotherapy, which is given to patients, to the females with breast cancer, that can affect the heart and the cardiovascular system. In breast cancer survivors, it is the cardiovascular mortality which is more than the oncologic mortality. They do not die mostly most of the times because of breast cancer, but it is because of the cardiovascular effects of it, of the treatment that the women die of. Then the treatment which is given to them with anthracyclines, doxorubicin, or trastuzumab, that can result in cardiomyopathy, and then they have to be treated for that. So you have to be cognizant, and you should understand whenever you are giving chemotherapy to your patients with breast cancer, they have to be followed up as far as cardiovascular system is concerned to see if it is not affecting the ejection fraction. Then the radiation therapy can have an effect, endocrine therapy can have an effect, and an ovarian suppression therapy can have the same effect. Next slide, please. Next slide. Now, when the other important cardiomyopathy which occurs in women is the Takotsubo cardiomyopathy, which actually is, when we look at the coronary microcirculation, it is innervated by neurons that originate in the brain stem and mediate vasoconstriction. And therefore, under stress, Takotsubo occurs more in women than in men. It results in transient reduction in ejection fraction, results in cardiomyopathy, which may be transient, but if it is repeated more, oftentimes it can result in a permanent damage. So you have Takotsubo cardiomyopathy, you have periportal cardiomyopathy, you have heart failure with preserved ejection fraction. Khalida, can you go to the previous slide, because that is the last slide which I have there. No, yes. So the take-home messages from this introductory presentation on heart failure in women is, remember, heart failure in women is, they have more of preserved ejection fraction. And we need to understand why it occurs. We need more data for that. The traditional factors when present portend increased risk of heart failure compared to men. Sex-specific factors account for distinct presentations of heart failure. This is what we need to know. And we need to understand why it occurs like that. So my message is that sex imparts on almost every facet of heart failure. The gender, when we talk of sex, what we mean is the gender. It imparts on almost every facet of heart failure, from epidemiology and risk factors to pathophysiology response and therapy, and ultimately the outcomes. So when we are giving these patients the guideline directed medical therapy, we need to understand how these drugs act in women, and that would determine the ultimate outcome in these patients, and also the adverse effects that we see in other cases as compared to women, maybe more because of the, as I said earlier on, because the drugs stay in the system for a longer period of time. Then in men, we have heart failure with reduced ejection fraction, and in women, we have heart failure with preserved ejection fraction. The risk factors like obesity, diabetes, and mental and psychological stress affect the women more than men. And also the socio-economic factors have an effect. Then, as I talked about breast cancer, chemoradiation therapy induce cardiomyopathy, and then we have periportal cardiomyopathy in women. There is a paucity of data as far as the women are concerned. Large gaps in knowledge which exist, which is needed. So this is, I think, what I've tried to do. Just a minute. Don't interrupt. What I've tried to do is that lay down the foundation of what heart failure is in women, more of microvascular disease, less of macrovascular disease, the more adverse effects with drugs. There are knowledge gaps, and we need more data for that. Thank you very much, and I'm sure that the subsequent presentations are going to expand on the heart failure in women, and we will be able to understand them better. Thank you so much.
Thank you, Dr. Shahbaz Qureshi, for the informative introduction of the theme of the webinar. There are definitely differences in the sex-specific heart failure symptoms and presentation and diagnostic modalities. Now we will move on the introduction of our chairpersons. As already we introduced Professor Shahbaz Qureshi. He worked in the Islamabad from 1974 to 2013, ex-professor of cardiology and medical college, Mirapur Khas. He is nowadays president of Spring Foundation Society, and they remain on various positions in the Pakistan Cardiac Society in past. So we are now moving towards the another chairperson, our worthy professor of the all cardiologists almost in Pakistan, Professor Azhar Faruqi. He was the founder, president of Pakistan Hypertension League, ex-president Pakistan Cardiac Society, and ex-professor of cardiology and ex-director of the NICVD. I remember he started diploma in cardiology during his tenure, and we did in it during the 2000 during the 1980s period. So our third chairperson is Professor Harun Babar Aziz, ex-president Pakistan Cardiac Society, head of the Department of and Professor of Cardiology and Director Cath Lab at Nishta Medical College University. The fourth chairperson is Professor Abid Amin. He was the professor of Gulan Medical College and past president of Pakistan Cardiac Society. Dr. Bilal Moyuddin, professor of cardiology, King Edward Medical College University, ex-general secretary Pakistan Cardiac Society, chairman Scientific Council on Hypertension in PCS, and now he is the coordinator of upcoming annual conference of the Pakistan Cardiac Society in November. Professor Dr. Rajkumar Satyavani is our next chairperson. He is the president-elect Pakistan Cardiac Society, professor and head of the Department of Cardiology, Ghulam Muhammad Meher Medical College, Sarkar. Professor Nawaz Lashari, chairperson and head of the Department of Cardiology, Dow University of Health and Sciences. And next slide. So we are now moving towards our first speaker. She is Dr. Hunaina Shahab, Assistant Professor of Cardiology, Mount Sinai West Hospital, New York. Her topic is heart failure myth and debunking the misconception for the woman. She will further elaborate the concerns in this regard as were mentioned by the Professor Shahbaz Qureshi. Dr. Hunaina, are you ready to share your slides?
Assalamu alaikum. Yes, I'm ready.
Yes. Please start your presentation. Yes.
Okay, so assalamu alaikum everyone. Thank you, Dr. Khalida, for this invitation and this excellent webinar on heart failure. I'm Hunaina Shahab. I'm the assistant professor in the Icahn School of Medicine in Mount Sinai West in New York. And Professor Qureshi gave a very great summary of the issues with heart failure in women. So the topic that I'm presenting today is the myths about heart failure and debunking those misconceptions in women. So the most common misconceptions about women and heart failure can be extrapolated from the myths about women and their heart health. And today we will talk about the 6 most common myths about heart failure in women. The first one is that heart failure is most common in men. It only affects older people. The causes and risk factors of heart failure are the same for both men and women. They both experience the same symptoms of heart failure. Women are less likely to die from heart failure, and men and women get equal treatment and get the same therapies, and both same therapies will work for both genders equally. So before we start with the first myth, which is heart failure more common in men, and with data, we will just debunk all of them one by one. We will talk about the data from Pakistan. And before we dig deeper into the heart failure data, we should see what is the overall cardiovascular disease data. The estimated age standardized incidence of cardiovascular disease in Pakistan is 918 as opposed to 684 worldwide per 100,000. And the age standardized death rate is 358 in Pakistan, higher than in the world of 240 per 100,000. As of 2006, Pakistan had an estimated 2.8 million citizens with a diagnosis of heart failure. And back in 2006, the total population of Pakistan was about roughly 159 million, which makes heart failure in about 1.8% of the total population. Now, there was a very interesting study that was published recently in 2024 in one of the JACS supplements by a group in Pakistan, and they studied the trends in the burden of heart failure. And what they showed was that in 2019, the age standardized prevalence and years lived with disability rates in Pakistan were 405 per 100,000 and 35.8 years lived with disability. And the trends in these rates have varied over the years. There's an increase in the rate of heart failure prevalence between 2000 and 2010. Then there was a decline in the prevalence of heart failure between 2015 and 2019. And then there was a slight increase. Females in Pakistan had a higher percentage increase in the prevalence of heart failure between 1990 and 2018 as compared to males. And that percentage increase was 0.04. The years lived with disability from heart failure also followed the same trends as the prevalence of heart failure. And just to give a brief summary, which is very interesting, that Islamabad had the highest prevalence of heart failure as compared to the other provinces, with the lowest being KPK. So KPK had the lowest prevalence of heart failure. And the trends basically in the subnational estimates were similar as in the entire country. Now, women-specific data in Pakistan is very limited. Overall, data in heart failure in women is limited all over the world. And in women in Pakistan, it's even less available. There was a recent study, again, published this year by a group from KPK, and they had studied 170 patients with heart failure. And in their study population, they noticed that males were 54%, and females were almost similar with 46%. So there was almost the same number of heart failure in men and women in Pakistan. If you look at data from the United States, and this is the data from the American Heart Association, overall prevalence of heart failure has increased to 6.5 million Americans above the age of 20, which has been projected to increase by 46% to about 8 million people. And even in their population, the heart failure in women and men is roughly similar: 2.6 million in women and 3.4 million in and 3.4 million men. So overall, heart failure affects both genders equally and is the leading cause of morbidity and mortality. So with this, the first myth that heart failure is more common in men has been proven false. Now coming to the next one, that heart failure only affects older people. Now, if you look at this particular slide, the lifetime risk of developing a coronary heart disease is 1 in 2 in men and 1 in 3 in women. However, for heart failure, there is an equal lifetime risk of developing heart failure at the age of 40, before 40, and even at the age of 80 years. So there's a risk of 1 in 5, or about 20% for men and women both, even when despite the age. So even if you're at 40 or at 80 years of age, the risk of developing heart failure is similar in men and women. The occurrence of heart failure does increase with advancing age, and women at an older age are at a greater risk than men. And of course, as Professor Qureshi explained, some of them being included, some of the issues come in from breast cancer and treatment and stress-induced cardiomyopathy. The rates of heart failure approximately double with each 10-year increase in age between 65 and 85. However, in women, this incidence rate triples between 65 to 74 and 75 to 84 years. Now, if you go back to the slide of heart failure data in Pakistan, it was interesting that this group saw that the ages between 10 years and 49 years saw an increase in the burden of heart failure, whereas the other groups experienced a decline. Now, this younger population can be because of, it could be because of a peripartum cardiomyopathy or myocarditis, etc. So this basically shows that the second myth that it only affects older people is also not completely true. Now, coming to the third myth, the causes and risk factors of heart failure are the same for both men and women. So as we know, and we just heard in great detail, that there is HFrEF affects more men and HFpEF affects more women. So when we look at HFrEF in particular, women have a lower lifetime risk of developing HFrEF, and they are more likely to have non-ischemic etiology of HFrEF. And amongst the hospitalized patients with heart failure with reduced ejection fraction, women were more likely to have hypertension, valvular disease, and less likely to have coronary disease, and less likely to have tobacco usage, but they were found to have higher natriuretic peptides. With HFpEF, there was a greater impact of obesity. So women were more prone to develop HFpEF, and the reasons for that is this inflammatory metabolic hypothesis. So inflammatory conditions like obesity, diabetes, and hypertension make the women more prone to developing HFpEF. Some of the reasons being socioeconomic status. Women generally are not found to have increased tobacco usage, but even those who do use tobacco, they still have a higher incidence of developing HFpEF. So overall, because of the inflammatory pathway, and I know that people will discuss this in the next presentation, but because of the inflammatory hypothesis, women are more prone to developing HFpEF. And there are specific cardiomyopathies which are related to women, which need to be talked about. One of them is cardiomyopathy, reversible or Takotsubo cardiomyopathy, and some which are a spectrum, like hypertrophic cardiomyopathy or amyloidosis. So I won't go into much detail with peripartum because we have a speaker who will speak about pregnancy and heart failure issues. But just briefly, childbearing is something which is unique to women only. And it's a high stress state, which causes large changes in cardiovascular physiology, and that may exacerbate adverse pregnancy outcomes like diabetes, hypertension, preeclampsia, eclampsia, and even peripartum cardiomyopathy. Now, the risk factors for peripartum cardiomyopathy include older maternal age, hypertensive disorders of pregnancy, multifetal pregnancy, and African American descent. And more than 50% recover typically around 2 to 6 months after diagnosis. Then there are certain other cardiomyopathy causes which have data for both men and women. For example, in amyloid, women at present with cardiac amyloidosis have a higher compared to men and a lower wall thickness. When we talk about hypertrophic cardiomyopathy, women with hypertrophic cardiomyopathy are typically older, more symptomatic at first presentation. They are more likely to have an obstructive physiology and have a greater mortality in women compared to men. With sarcoid, women have a lower utilization of endomyocardial biopsy. They have a lower rate of ventricular arrhythmias and subsequent ICD implantation, and have a higher inpatient in-hospital mortality as well. With Takotsubo cardiomyopathy, emotional stress is more common in women compared to men. Stress cardiomyopathy overall is more common in women, and emotional stress plays a huge role. Physical stress is playing part in those men who develop stress-induced cardiomyopathy. And males in general have more adverse outcomes with stress-induced cardiomyopathy, with more heart failure, more arrhythmias, and cardiovascular death as compared as the incidence of breast cancer in women. So because the women are living much longer now with breast cancer, there is an increase in cardiovascular mortality amongst patients who have breast cancer compared to cancer mortality. Specific treatments like doxorubicin and trastuzumab have cardiotoxic effects. So doxorubicin cardiomyopathy occurs in 10% of people, or 10% of people who are taking doxorubicin. And amongst all people who take trastuzumab, there's 13% of cardiotoxicity with trastuzumab. Radiation therapy causes valvular cardiomyopathy, affects the valves, which then eventually causes cardiomyopathy. It can also cause ischemia and eventual HFpEF. And there are certain types of autoimmune diseases like SLE that are more common in women, and that predisposes them to have cardiomyopathy and a higher development of heart failure. So clearly, the causes and risk factors of heart failure are not the same for both men and women. And again, this myth has also been proven false. Now, the next myth, men and women have the same symptoms. So overall, the signs and symptoms may be similar, but compared to men, the frequency of exertion, they have more difficulty in exercising and have higher incidence of edema. And despite controlling for age, ejection fraction, women than men for intermediate activities of daily living and social activity. Depression is common men. And most not experience symptoms. Now, the second myth that women are less likely to die from heart failure. And overall, the incidence of heart failure has declined among women, but not men, whereas the survival of onset of heart failure has improved in both men and women. Men and younger persons have experienced larger survival gains compared to women and elderly. But overall, women with heart failure tend to survive a little longer than their male counterparts. This is more apparent when the etiology is not related to ischemia. Women with heart failure due to non-ischemic causes have a better survival than men with or without coronary artery disease. There's an increased mortality rate in women and men when heart failure evolves from coronary artery disease. Women are much more likely to develop heart failure after an MI, and this again may be because they receive less treatment or less aggressive treatment than men. And even though the clinical manifestations of heart failure appear to be severe in women with HFpEF, after adjustment for baseline differences, heart failure hospitalizations are not increased and survival expectancy is better for women compared to men. So this myth that women are less likely to die is not completely false. And the last myth, that men and women get equal treatment and same therapies will work for both genders equally. Now there's a vast, great underrepresentation of women in heart failure trials. Now, I'm not sure if this is projecting well, but overall, the underrepresentation is so bad that average representation of women or percentage of women in all these major heart failure trials was roughly about 20%. The highest was TopCat, that was 51%, and the lowest was 19% with the CIBIS trial. Other than TopCat, almost all of them had only roughly about 20% representation of women. So the data severely lacks amongst women and heart failure treatment. With regards to equal treatment, so not all heart failure medications benefit men and women equally. And I know that there's a presentation right after that, so I won't go into much detail. But overall, ARBs are better than ACE inhibitors for women. And that is probably because of sex hormones and estrogen stimulating the ARB receptor, which is why ARBs are better at controlling heart failure in women than men. Women are less likely to have ICD insertions And even then, ICD has an unclear benefit amongst women. And even though CRT has an improved benefit for women, women get lesser implantations of CRTs overall. They are also less likely to receive mechanical circulatory support for cardiogenic shock, and they are more prone to developing complications with these mechanical circulatory supports. So there are a few trials that show about the ICD, and they did a meta-analysis of that. So there's some data with regards to that. So overall, we've seen that there is a lot of discrepancy amongst what people believe about heart failure in women and what actually exists. And the question now is, how do we improve on these myths and find strategies to balance the scales in sex disparities in heart failure? And some of them being, we increase or try to increase enrollment of women in heart failure clinical trials, try to keep men and women 50-50 or almost similar. We try to improve our understanding about the pathophysiologic differences of heart failure in men and women. We try to focus on optimization of sex-specific risk factors. We ensure equitable access to heart failure and therapies, and we deconstruct disadvantages and barriers to care where women are concerned. Thank you so much. If there's anything, I can ask the questions now, or maybe we can take the questions later.
Okay. Thank you, Dr. Nena, for your valuable presentation. Her presentation covered the incidence, really interesting incidence of heart failure in women, and she proved the last myth that heart failure is more common in men than women. We will now open the floor to our chairpersons for any questions. I have seen one of the questions from Sultana for Dr. Hunena. She is asking how smoking is affecting women's heart failure. How smoking is affecting and preventing.
So smoking overall causes inflammation in the body. And overall, when we see that, so smoking can cause two effects. One is that it could cause coronary artery disease, and that can cause heart failure. The other thing is, and I'm just going back to that slide, is the inflammatory metabolic hypothesis. So when women are smoking, they add to that inflammation, or they're more prone to inflammation already. So smoking adds to that inflammation in the body. And in combination with other risk factors, that enables them to develop more HFpEF because of more inflammation.
Another question, which is in the chat box from the Ali Imran. He asked that whether women's hormones are responsible to have novel coronary artery disease, or how nutrition affects heart failure.
Yeah, so that's a great question. So yeah, women's hormones, until menopause, women are more protected from coronary disease. Now this is important. We know that there is more HFpEF in women compared to HFrEF. And there's a higher incidence of coronary artery disease causing heart failure in men as opposed to women. Until menopause, women hormones protect from coronary artery disease. Now it's not 100%, but it still has a protective risk factor. So sex hormones will help in lower coronary artery disease incidence in women. And nutrition obviously affects heart failure, but that is when mostly, with regards to diabetes and hypertension. If your nutrition is not good and you have genetic predisposition, you can develop diabetes, hypertension. And those people who have had hypertension, so men compared to women, those who have hypertension, and if with men and women having the same incidence, women with hypertension have a 3-fold more increase in heart failure incidence compared to men. So men are 2 times more likely with hypertension to develop heart failure, but women with hypertension have 3 times more risk to develop heart failure.
Now, I
So
will invite-
basically, it is the risk factors which affect the women differently as compared to the men, which actually results in the manifestations of heart failure in women. And then the differences between the microvascular involvement in women and the macrovascular involvement in men.
Khalida,
Now
can
I
I
will-
ask
I
a
will-
question, Khalida? Do you
Yes,
listen to me?
Doctor. Yes, we can hear you.
The
Dr.
question
Abid
is,
Amin?
yeah, in Western population, after menopause, majority of the women, they take a hormone therapy. So does that affect more women than men in the elderly population, and particularly in women after the menopause? So Hunana, can you comment on this?
Yeah, sure. So, I practice here, and not all women are taking hormone replacement therapy in the West, and they're quite cognizant of the fact that hormone replacement therapy causes other kind of issues, and they're more prone to clots, etc. So not a lot of women are on hormone replacement therapy, but even then, those who are on hormone replacement therapy, the combination of estrogen and progesterone has, in some studies, actually shown to make their cardiovascular outcomes worse as opposed to just progesterone only. So even if women who are on it, and if they're on combination ones, especially, then as cardiologists, we're trying to keep a very close eye on their cardiovascular disease incidence.
So now,
Can I add something to it? It is actually postmenopausal. What happens is the risk of increasing risk factors बहुत बढ़ जाते हैं, or cardiac risk factors that predisposes women after menopause, that predispose women to heart failure due to the presence of or increase in risk factor, cardiac risk factors. Yes.
getting late, but now I will invite Professor Harun Aziz Khan Babar to give his comments on Hunaina's presentation. Dr. Harun Babar Aziz, are you there?
Can you hear me?
Yes, we are hearing.
Yes, Professor Khalida, thank you very much for inviting me to this webinar. First of all, I would like to thank and congratulate all the presenters, excellent presentations. I would just like to make one comment, because in our culture and in our society, women are unable to keep themselves physically fit. If we see in our society, most of our women in middle age or even in early middle age, they become obese. There is no exercise program, and even they become more depressed, and there is no stimulation for them to seek medical advice as well. And there is a lot of neglect and ignorance on part of us, as well as on part of other doctors and media, and all of us are, I think, responsible for this. So we should make a special preventive. We should take measures that we should give them this awareness that if they keep proper diet, if they keep their BMI within the range, and if they do regular exercise, they will be equally be beneficial for them. And of course, if once a woman develops cardiac failure, the mortality and morbidity increases much more in one part of the life, one part of the period of the life as compared to men. But if we are preventing these problems, it will go a long way to prevent the disease and to cure them and to treat them. Thank you.
Thank you, Dr. Babar Aziz, and thank you, Dr. Hunaina, and our other chairpersons for discussion on these important and valuable questions from the practice point of view. Moving ahead, we now invite Dr. Saddaf Shabir Dayani consultant cardiologist, Kashmir Institute of Cardiology. She will present on heart failure and aging, challenges faced by the older women. Dr. Sadaf, are you there? Dr. Sadaf?
Assalamu alaikum. Can you hear me, ma'am?
Yes, we are hearing you.
Allow me to share my screen, please.
We have already.
Is my screen visible?
It
Can
is
you see
visible.
my slides?
Yes, ma'am.
Yeah, you need to go to full screen.
Yes.
It's okay. It's okay now. It's full screen.
अब ठीक है?
बिल्कुल ठीक है.
Assalamu alaikum. I am Dr. Sadaf and I am working as cardiologist in Kashmir Institute of Cardiology, DHQ Mirpur. And I would like to thank Madam Khalida and Madam Nusrat for inviting me to this webinar. So I'll take further the discussion which has already been started by Sir Shehbaz Qureshi and Dr. Hunaina. So my topic is heart failure and changes in challenges faced by older women. For the sake of this presentation, the older woman is being referred to the postmenopausal woman, and it also includes women who are above 80, but mostly the focus of presentation will be on postmenopausal women. So, first of all, the definition of heart failure. The heart failure, universal definition of heart failure requires signs and symptoms of heart failure, which we all know as dyspnea, ankle swelling, fatigue, pulmonary edema, and elevated JVP, along with structural and functional cardiac abnormalities with at least one of the following, which are elevated natriuretic peptides or objective evidence of systemic or cardiogenic pulmonary congestion. Over the last decade, the heart failure classification has been based on the EF number. So we all know that there is heart failure with reduced ejection fraction with EF less than 40, mildly reduced or mid-range ejection fraction with EF 41 to 49%, and heart failure with preserved ejection fraction, which is associated with EF more than 50%, along with cardiac structural and functional abnormalities and evidence of raised filling pressure, such as increased left atrial volume index, increased natriuretic peptides, and diastolic dysfunction. Epidemiology of heart failure, I'll just briefly, Dr. Hunaina has told already in very much detail. So around 2.6 million females are affected with heart failure, and the data of Pakistan has been shared by Dr. Hunaina already. Traditionally, risk of HFrEF is lower in women, almost half of the risk in men, and HFpEF is more common in females. At 40 years of age, the risk of developing heart failure is similar for both men and women, and that is 1 in 5. But after the age of 65 years, it doubles for men and triples for women in the coming decade until 85 years of age, after which it again becomes equal in both genders. The etiology of heart failure in women is multifactorial, and in postmenopausal women, the most common causes are including the premorbidities, general premorbidities, hypertension, valvular heart disease, diabetes, coronary artery disease, and stress-induced cardiomyopathy, which is more specific for women. And in younger patients, postpartum cardiomyopathy, autoimmune disorder, collagen vascular disorder, cardiotoxicity, genetic cardiomyopathy, alcohol toxin tachycardia, which could be due to thyroid or any other cause. So there are 9 predictors of heart failure which have been documented in the famous HER study in postmenopausal women, and they have to be kept in mind by evaluating every woman for heart failure. So these are diabetes, hyperglycemia increases the risk of heart failure with hazard ratio of 3. Atrial fibrillation, myocardial infarction, CKD with creatinine clearance less than 40 ml per minute, hypertension with systolic BP more than 120, current smoking, obesity with BMI more than 35, LBP on ECG, and LV hypertrophy. What are this has already been shared by Dr. Hunaina, but I'll just briefly describe. It is important to understand the gender differences On the basis of epidemiology, we have already discussed that women have less risk of heart failure with reduced ejection fraction and are more likely to have non-ischemic etiology of heart failure with heart failure. And the survival benefit of ARBs is more in women as compared to ACE inhibitors. However, no such discrimination is present in men. Among the device therapy, eligible women are less likely to have an ICD inserted. The cause of this is elucidated as females are less likely to develop ischemic cardiomyopathy. So ICD is going to be less helpful in their management. And there is unclear benefit because ICD shocks and benefit with ICD. In contrast, if CRT is placed in women, it gives more benefit as compared to men. For advanced heart failure management, first the females are referred, very less number of females are referred for advanced heart failure management. Again, they are more likely to develop complications of advanced heart failure therapy and medical circulatory support. And almost only 25% of females with heart failure are referred for heart transplantation as compared to men. So the presentation of heart failure in women varies. And in addition to the cardinal symptoms, we have to keep these things in mind, that the women with the heart failure will be presenting at an older age as compared to men. Majority will have heart failure with preserved ejection fraction. Diastolic dysfunction is usually present. Women are more symptomatic. So this is important to understand that women have a small LV cavity size as per body surface area. And we usually do not do measurements on echo according to body surface size, and we think that the LV size is normal by their heart failure. We should keep in mind that female has a smaller LV cavity size than men, and they are more likely to have concentric hypertrophy. So at similar end diastolic volumes, females have higher end diastolic pressures compared to the men of the same age. So they are more symptomatic, more dyspneic with heart failure. The quality of life indices are worse for women with as compared to men, and depression is more common in women with heart failure. So there are different factors which hinder the treatment of the patient with heart failure and who are elderly or postmenopausal. Number one is frailty and reduced physical resilience, muscle loss, decreased bone density. So there is difficulty in coping with heart failure symptoms. Women generally have multiple comorbidities such as diabetes, arthritis, anemia, depression. They are more likely to present with preserved dementia. The complex medication are difficult to be managed by women, as we all know that the literacy rate in our women in rural setups is very low. They cannot understand how to take the medication in polypharmacy, and they're less likely to be compliant. And usually the female is the caregiver in the family, so no one takes care of the female. As a result, she does not comply with hospitalization. Then there are healthcare access barriers. Again, females in our setups are dependent on males to get them to the hospital for their follow-ups, for their checkups and investigations, transport. They have transportation and financial limitations. Then they have the burden of caregiving, and there is very low health literacy. There is no concept of giving mass education about heart failure or heart failure symptoms and management. They cannot comply if the family is already financially compromised. Then they cannot cook a separate meal for the who is cooking for the whole family. So there are dietary restrictions. They cannot completely follow. There are exercise limitations due to these joint pains and arthritis. And there is a lack of tailored exercise program. There is no concept of rehabilitation in our country, as we all know, and there is no concept of rehabilitation at all. So as a result, they have repeated hospital admissions, but this is at the stage of advanced heart failure where nothing much can be done about them. And there are decisions regarding advanced care and quality of improving quality of life are difficult to be made because the family does not support them as much. Then again, there is economic strain and impact of fixed incomes and societal pressures on women to care for others. Cause them to suppress their symptoms and their problems, and they cannot face it until they stand in emergency. So there is also stigma about heart failure, like previously patient used to hide that they had TB or as also a stigma, patient hide the symptoms of heart failure just for not being infamous. Should heart failure approach which should incorporate a multidisciplinary just geriatrician, mental health professionals, depression and mental health are very societies, and majority of people with issues are depressed and need some antidepressants along with the therapies. Then there should be tailored treatment plans which should be individualized or customized for each patient. We should increase health literacy, give them brochures. We can start an OPD clinic of heart failure for women and mass educate them a good 20 female people. Then they diagnose their status and how should they comply with the diet as well. Access to exercise programs and dietary support, community-based resources. In our system, we can use community-based resources by incorporating fees in our healthcare system for their weekly or twice weekly visits to the patient who cannot come to hospital every week for follow-up to keep a check on their medication compliance and their lifestyle. So management of heart failure in older women, initially, we should address the cause if it is underlying CAT, menopausal older women. So CAT should be ruled out first as a cause of heart failure, and then risk stratification and management of other comorbidities should be done, which are hypertension, diabetes, obesity, AF, CKD, depression, OSA. Then are not available here. The symptom management includes the symptomatic therapy and disease modifying therapy with loop diuretics, SGLT2 inhibitors, MRAs, ARNIs, and ARBs. The diagnosis of this, because we all know likely to have heart failure with preserved ejection fraction, so we must be able to diagnose, although there are 2-3 criteria about echo. First of all, in the initial workup or pre-test assessment, we should see symptoms and signs of heart failure, risk factors, ECG showing LVB or LVH, echocardiography, natriuretic peptide, and 6-minute walking test. Then we should do echo. And in advanced testing, we have diastolic stress test and workup for including CMR and genetic testing. If we do not do all these fancy tests and just focus on the symptomatology and do a good echo and exercise tolerance test, we can diagnose a heart failure with preserved ejection fraction and grade the severity of the symptoms. So echo parameters which should be kept in mind. It is not necessary to remember all the numbers. The more the numbers, the more likely the patient is to have heart failure, and more than 5 points is diagnostic of heart failure. So in short, we should have a E to E prime ratio less than 9. And LA volume index less than 29, NT-proBNP less than 25 if patient is in sinus rhythm, and NT-proBNP less than 365 if patient is having AF, because AF is itself associated with raised NT-proBNP levels. So anything above this puts the patient on the risk of heart failure with number more like diagnosis of heart failure. So this is a treatment from AHA 2021 guidelines in which only one therapy, SGLT2 inhibitors, is class 2 and all the rest of the therapies are 2B for decreasing mortality. Diuretic is class 1 for reducing congestion and symptoms. In the latest ESC guidelines of 2023, SGLT2 is class 1 and all the rest are class 2B, and one other drug which has been introduced is Finerenone, which is a non-steroidal MRA. And his health has been shown to be hospitalization in patients with rejection. So the long-term management includes monitoring of hospital course, which should know the reason for admission, the sentinel symptoms for which patient was admitted, what was the congestion status at start, during the hospital stay, and at the discharge, what was the diuretic dosing used, and how much dose of diuretic was upgraded, or any rescue diuretic added or not, any unexpected events occurred or not. Then we plan for GDMT optimization, monitor RFTs and electrolytes, plan and test, follow-up of comorbid conditions like OSA, CKD, diabetes, AF, and all anemia. And then advanced care planning for prognostic assessment for heart failure transplantation, MCS, or any palliative care referral. So it's a circle of the care team, the skills and members, and it includes and ongoing monitoring, prescription titration and monitoring of GDMT, patient and caregiver education about prognosis, psychological support, which is very important, coordination with primary care specialists, referral to palliative care when required. It is a complex entity of physiological, psychological, and social factors, and holistic approaches should be initiated to improve quality of life for elderly women with heart failure. And we should encourage further research and interventions to support this vulnerable population and educate of patient which device is the studying the role of estrogen HRT for prevention or amelioration of symptoms of heart failure in postmenopausal women. So many people were discussing this after the previous presentation. So the role of estrogen is multifactorial. It improves the diastolic function by early calcium homeostasis regulation. It decreases the concentric hypertrophy. And menopause when the estrogen declines, all these protective effects are gone. So the calcium homeostasis disturbs and early diastolic dysfunction, and then due to concentric abnormalities occur, and as a result, patient develops diastolic dysfunction and symptoms of heart failure. Estrogen for prevention of heart failure, but several studies which have been done have shown some benefit, not to a level, but there are studies which have shown benefit of estrogen or HRT in prevention of symptoms of heart failure in women and decreasing the mortality. So these are the few references, and this is the end of it. Thank you.
Her presentation focused on unique challenges older women faces with heart failure. And she explained how we can manage their care better. Let's proceed towards the question answer with on chat box. From Sultana Habib, issue in the diagnosis of heart failure in women is improper utilization in cardiac modalities. It is not all adequately utilized, and its treatment remains under utilized. Sultana, is this comment or question?
Comment. Looks like a comment.
Okay. So I will ask Professor
I think the
Abid.
speaker can tell me how does she feel about it. Is this the reason? This is how I feel in my practice. Women are actually not properly diagnosed for their radiology. Echo करते हैं हमारे यहाँ और कह देते हैं heart function normal है, heart failure with preserved ejection fraction, and they start the routine therapy. That's why I wrote this question.
Okay.
In general, in our practice,
yes.
In general, in our practice, you are very right that we usually ignore diastolic dysfunction. एक concept बना हुआ है कि बस 50 years से ऊपर female है, diastolic dysfunction grade 1 आ गया, हाँ ठीक है. We don't see कि ये patient OPD में कितनी दफा dyspnea on exertion के साथ आती है. हमने ETT भी कर ली, हमने angio भी कर ली, coronaries भी normal निकल आई, लेकिन patient का dyspnea ठीक नहीं हो रहा. तो एक तो ये कि बेसिकली हमें अपने एको रूम्स में ये अप्रोच रखनी चाहिए कि हमने हर पेफ के लिए भी देखना है, हर फीमेल पेशेंट जिसका डायस्टोलिक डिसफंक्शन आ रहा है उसकी हमने ई टू ई प्राइम रेशो, सेप्टल ई वेलोसिटी, टी आर जेट वेलोसिटी, ये चीजें एलए वॉल्यूम इंडेक्स चले, थोड़ा टाइम उसमें ज्यादा लग जाता है, लेकिन एटलीस्ट सेप्टल वेलोसिटीज और ये चीजें हम देख सकते हैं और एंटी प्रो बीएनपी एडवाइस कर सकते हैं कि हार्ट फेलियर विद रिजर्व्ड इन्फेक्शन अगर है तो टाइमली डायग्नोसिस इसके लिए फिर
I just want to say that every case of diastolic dysfunction does not mean heart failure with reserved ejection fraction. Just
Yes, ma'am. But we
इसमें
should
actually
think about it. Point is,
मैं एक इसमें थोड़ा सा ऐड कर दूं, वो ठीक है आपकी बात के डायस्टोलिक डिसफंक्शन अगर है सिर्फ तो doesn't mean that the patient has heart failure. What you can do is do a diastolic stress test. तो उसमें जब आपको उसका जो चेंज नजर आएगा ना, from stage grade 1 to grade 2, so then the symptoms of breathlessness are because of heart failure with diastolic dysfunction. और दूसरी चीज जैसे डॉक्टर सदफ ने कहा ना कि you actually measure the E to E prime, तो आप लेफ्ट वेंट्रिकुलर फिलिंग प्रेशर्स को जब देखते हैं ना, और लेफ्ट वेंट्रिकुलर फिलिंग प्रेशर जब 14 से ज्यादा जाएगा, तो then the symptoms are due to diastolic dysfunction. तो इसको इग्नोर नहीं करना चाहिए। और दूसरी चीज जो है वो कि द लेफ्ट कल इज स्मॉलर इन वुमेन, और इस वजह से कार्डियक आउटपुट और स्ट्रोक वॉल्यूम कम होती है, जिसकी वजह से फिर ये जो ब्रेथलेसनेस है इनमें ज्यादा होता है। सो यू नीड टू एक्चुअली treat the comorbid conditions.
yes, that
So
makes
now our next chat box is from are discussed like fatty liver, depression, bipolar, dementia, and GIT diseases in old age. Healthy lifestyle, medicine, and integrated to manage heart failure in addition to drugs. Dr. Abid Amin, are you there? Dr. Sadaf?
yes, ma'am. मैम इसमें जो
Yes.
हमारे मल्टी डिसिप्लिनरी केयर टीम का कॉन्सेप्ट है वो यही है कि आपने हार्ट फेलियर के लिए तो मैनेज करना है, लेकिन पेशेंट के जो एसोसिएटेड कोमॉर्बिड्स है उनको भी आपने एड्रेस करना है, और साइकोलॉजिकल इश्यूज को आपने एड्रेस करना है। जाहिर है साइकेट्रिक जो उसकी ट्रीटमेंट चल रही है उसको वो हम नहीं एडवाइस कर सकते कि तुमने इसे कम करना है या ज्यादा। वी हैव टू इन्वॉल्व अ साइकोलॉजिस्ट और अ साइकेट्रिस्ट जो उसको उन ड्रग थेरेपीज को मॉनिटर करे, क्योंकि एंटी साइकोटिक्स या एंटी डिप्रेसेंट्स का डायरेक्टली हार्ट फेलियर से कोई रिलेशन नहीं है। वो एक एरिथ्मोजेनिक जो पोटेंशियल है टीसीएस का, और वो एक अलग चीज है, लेकिन हार्ट फेलियर सिम्टम्स उसकी वजह से वर्स नहीं है। जो इसमें कॉमन चीज है सबसे ज्यादा जो हमें देखने को मिलती है, डिप्रेशन है, जिसकी वजह से पेशेंट दवाई छोड़ता है। तो उसमें
Actually,
ये एक तो हमें इनको अर्ली स्टार्ट करने चाहिए, एसएसआरआईज और समथिंग, कीपिंग इन व्यू कि कोई उसको टेकिकार्डिया ज्यादा ना हो, हार्ट रेट ऑप्टिमम।
डॉक्टर साहब बेसिकली प्रॉब्लम ये है कि जो हार्ट फेलियर है ना, जब किसी को आप कहेंगे ना कि इसको हार्ट फेलियर हो गया है, तो उसके जो साइकोलॉजिकल इम्पैक्ट है और डिप्रेशन जो है, दैट्स अ पार्ट एंड पार्सल ऑफ इट। सो आपको यू कैन इन्वॉल्व अ साइकियाट्रिस्ट और अ साइकोलॉजिस्ट इन इट, बट आई थिंक क्योंकि आप उस हार्ट फेलियर को ज्यादा समझते हैं एज अ कार्डियोलॉजिस्ट, तो इन माय ओपिनियन एंड व्हाट आई डू इन माय प्रैक्टिस इज that I try to put them on antidepressants और जो सेफ हो, और उसके साथ उनका जो है मैनेजमेंट बेहतर, और थोड़ा सा उनको आपको खुद मोटिवेट करना पड़ता है। मल्टी डिसिप्लिनरी बहुत अच्छी है, लेकिन हमारे यहाँ जब एक पेशेंट को आप एक जगह से दूसरे जगह भेजेंगे फिर किसी और के पास, तो उसके साथ जो एक तो एक्सपेंसेस बढ़ते जाएंगे, फिर उसके बाद take responsibility and coordinate everything, और फिर उसको वो मैनेज करे, तो वो ज्यादा बेहतर रहता है in these circumstances.
Can I add one more? Can I add one more comment?
You can ask question in the end because we have already late. Now I will invite Dr. Abid Amin to give his comments on this presentation. Abid Amin, are you with us?
no, I don't think so.
No, so he is not.
किसी और से करवा लें आप,
नहीं टॉक
I will
कर
ask
देना।
Professor Azhar Faruqi to give his comments on this presentation.
I would love it. but I am going to keep my concluding comments till the very end. So why
Okay.
don't we have
Yes, that will be.
someone else? So I would like to speak, but in the end. Thank you.
हाँ, Khalida, एक important comment है जो I wanted to add to this Sadaf presentation was that इसमें देखा ये गया है कि women does exercise has more beneficial effect than men. Simple सा failure in women अगर exercise that is more than enough to make them better. Quality of life उनका improve हो सकता है. Along with walk के साथ exercise के साथ उनका cerebral perfume improve कर जाता है. So that can also improve on the depression side of heart failure, which causes depression and then it precipitates the heart failure indirectly. एक vicious cycle बन जाती है. So exercise is one sole thing which can be recommended in our women. It is cheap, it is nothing. So this can significantly improve symptoms of heart failure.
Dr. Sultana, इसमें मैं अर्ज करूं कि
We
जो
are now
cardiac
moving
rehabilitation.
towards another presentation. You see? We are-
Okay.
Okay. So now we are moving towards the presentation of the Dr. Naila Qureshi. Her topic of presentation is pregnancy and heart failure, understanding the risk and management. Dr. Naila, are you there?
Yes, ma'am. Ma'am,
Can you
please
share
share.
your slide or you will share yourself?
Ma'am, your side, you please share the slides.
Okay.
Assalamualaikum everyone. I am a Dr. Naila Qureshi, working as a consultant gynecologist at Syed Abdullah Shah Institute of Medical Health Sciences at 7. Next. Introduction. Heart failure remains the most common major cardiovascular complication arising in pregnancy and the postpartum period. Mothers who develop heart failure have been shown to experience an increased risk of death as well as a variety of adverse cardiac and obstetric outcomes. Recent studies have demonstrated that the risk to neonate is significant. Next. With increased risk in perinatal morbidity and mortality, low ABGAR score, and prolonged neonatal intensive care unit stays. Information on the KUL factors of heart failure can be used to predict the risk and understand the timings of onset, mortality, and morbidity. A variety of modifiable, non-modifiable, and obstetric risk factors as well as comorbidities are known to increase a patient's likelihood of developing a heart failure. Next, please. Maternal cardiovascular physiology. During pregnancy, anatomical and physiological hemodynamic changes within the maternal cardiovascular system are orchestrated to support the health and safety of the mother and her fetus. Increase in plasma volume leading to a physiological anemia and maternal heart rate occur, and arterial blood pressure and systemic vascular resistance decrease. Cardiac output increase beginning in early pregnancy because of increase in stroke volume and is maintained further by a way of tachycardia. Next, please. Changes in maternal cardiovascular physiology, pregnancy, cardiac output, heart rate, stroke volume, plasma volume, and left ventricle dimension increase, and labor, cardiac output, preload, systemic sympathetic stimulation increase, and early perfurum, that is systemic vascular resistance, A and B, these are the chemoreceptor, B and B increase. Decrease is systemic vascular resistance in pregnancy and blood pressure. And early purpurum decrease is cardiac output. Next, please. Causes and timing of heart failure. Heart failure is the most common complication of a cardiac disease in pregnancy, with prevalence report from 13% in a large worldwide registry of women with pre-existing cardiac disease to 33% in women with pre-existing cardiomyopathies. Heart failure prevalence among postpartum and antepartum hospitalization have increased from 2001 to 2011, and the proportion of women diagnosed with peripartum cardiomyopathy is rising in the past decade. Despite the poor prognosis associated with the heart failure in pregnancy, the literature appears incomplete. Next, please. These are the causes of various causes of heart failure in pregnancy, like cardiomyopathy, congenital heart disease in the adult, arrhythmias, ischemic heart disease, like acute myocardial infarction, then cardiac artery, coronary artery disease, and chronic ischemic heart disease, pulmonary hypertension, and valvular heart disease, like MS, aortic stenosis, mitral regurgitation, and aortic regurgitation. Next, please. Risk factors. Multiple studies have established that demographic risk factors for the development of a maternal heart failure, older age, tobacco use, alcohol use, drug use, and insurance under either Medicare or Medicaid. Heart failure in pregnancy is more than twice as common in Black women compared with the white woman, and is least common among Hispanic women. Moreover, patients may have a multiple cardiac diagnosis and medical or obstetric issues, placing them at an additive risk. As patients are not soiled, mother may have cardiomyopathy and coexisting pulmonary hypertension or mitral stenosis and pulmonary hypertension, placing her at additional increased cardiac risk. And these are the interplay of risk factor. Maternal cardiac etiology, we already discussed the dilated cardiomyopathy, hypertrophic cardiomyopathy, peripartum cardiomyopathy, valvular heart disease, adult congenital heart, then pulmonary hypertension. These are the various risk factors like modifiable factors, obstetric factors, comorbidities, and non-modifiable factors. Modifiable factors include obesity, tobacco use, alcohol use, substance abuse, hyperlipidemia, Medicare and Medicaid, and insurance. Then obstetric factors like eclampsia, pre-eclampsia, gestational hypertension, gestational diabetes, hemorrhage, placenta previa, abruptio, accreta, multiple gestation. Comorbidities like hypertension, coronary artery disease, WHO 3 or 4, NEHA classification more than 2, pre-pregnancy heart failure, chronic kidney disease, diabetes. Non-modifiable factors like Blake race, age, and anticoagulant use. Adverse maternal outcome associated with the heart failure, like maternal death, prolonged hospital stay, cesarean delivery, pulmonary edema, renal failure, adult respiratory distress syndrome, then cerebrovascular disease. These are the indicator of poor prognosis like multiple comorbidities, Blake race, and older age. Timing, end of second trimester and peripartum, postpartum. Next, please. Risk factor in peripartum cardiomyopathy. Several studies have shown that the majority of the patients with peripartum cardiomyopathy are Black, and incidence is high among the Black women and lowest among the Hispanic women. As in true for a maternal heart failure overall, the association between the peripartum cardiomyopathy and preeclampsia is well established accounting for approximately 1/3 of women, whereas the other 2/3 occurred in other form of heart disease. Adverse maternal outcome. Mothers with a diagnosis of heart failure more than 7 times more likely to die. Maternal mortality was higher in patients with heart failure, 4.8% compared with those without, 0.5%. Much of the data on maternal outcome offer understanding because of the data set used or the period of time studies. Some studies focus only on in-hospital deaths, where admission-related or inpatient complication are accounted for, thereby failing to identify the patients managed in an outpatient setting and death that occur outside the hospital later after pregnancy that are not attributed to being pregnancy related. Adverse perinatal outcome. Assessing the true impact that maternal heart failure has on the babies born to affected mothers is a difficult task, as there is a paucity of data on fetal and neonatal outcome. This may in part be related to a lack of centralized national US debates on mother, detailed delivery information, outpatient information, and child outcome data. Recent studies have shown that experiencing a heart failure during pregnancy, particularly because of known cardiac disease, puts fetuses for a perinatal mortality. And this is a chart. Next, please. Okay, adverse neonatal outcome associated with the maternal heart failure. These are the different causes of heart failure. Maternal heart failure or heart disease like cardiomyopathy, hypertension, preeclampsia, multiple gestation, or smoking during pregnancy. They affect the fetus in form of adverse neonatal outcome, low birth weight, small for gestational age, infant respiratory distress syndrome, lower Apgar score, prematurity, and mortality. Since symptoms and detection of heart failure, already we discussed, many normal symptoms in pregnancy may mimic the heart failure. Signs such as peripheral edema, palmar arrhythmias, systolic murmur, and a third heart sound further complicate detection of a cardiac decompensation. Signs that warrant further investigation for cardiac disease are clubbing, resting tachycardia, any type of arrhythmias, hypertension or hypotension, hypoxia, tachypnea, elevated diastolic murmur, murmur radiating beyond the left sternal edge, murmur associated with a thrill, marked peripheral edema or evidence of a pulmonary edema. Symptoms such as shortness of breath and orthopnea also indicate a need for further consideration. The interdisciplinary cardio-obstetric team maternal care regime in order to provide a moderate and high-risk mother with effective care aimed to preventing heart failure and other associated adverse maternal and fetal outcomes, a distinct multidisciplinary approach coordinated among experts from a cardiology, obstetric, maternal fetal medicine, obstetric anesthesiology, neonatology, nursing department, pharmacists, and social workers must be in place. This form the cardio-obstetric team, which should occur before pregnancy, at the pre-conceptive stage or within routine cardiology or gynecology visit to prepare patient for the consideration that are in their future. This is the totally conclusion of care in cardio-obstetric framework. Like first is perinatal counseling, contraception, health assessment, and risk assessment. Second is decision making, plan to pursue pregnancy. Third is pregnancy monitoring, vigilance for warning signs and symptoms. Fourth is peripartum planning, plan for a safe delivery and mode of delivery. Five is immediate postpartum care, monitor in hospital, discuss lactation and contraception. Six is close outpatient follow-up, monitor for symptoms and discuss future pregnancy plan. Therapeutic and principle of management. When a pregnant or a postpartum woman present in acute heart failure, initial goal should be stabilize the patient, confirm the diagnosis, assess the severity of heart failure, assess the fetal status and viability, and contact member of an interdisciplinary cardio-obstetric care team. Any reversible factor that may have contributed to the patient's presentation, such as anemia, thyroid dysfunction, pulmonary embolism, preeclampsia, eclampsia, or infection, should be addressed. The last initial step is to assess the fetal viability as well as stability. Steroids can be considered if there is a concern for poor fetal lung maturity. Next, please. This is the management of heart failure in pregnancy, pre-existing or new cardiac disease like peripartum cardiomyopathy, dilated cardiomyopathy, or hypertrophic cardiomyopathy. Congenital heart disease, valvular heart disease, ischemic heart disease. Acute heart failure presentation, patient present with shortness of breath, dyspnea, orthopnea, marked pitting edema, elevated JVP. First of all, our aim to stabilize the patient and then send some investigation like ECG, X-ray and CTA. The cardio-obstetric team assess the fetal viability and stability, steroids if needed for a lung maturity. Treat comorbidities like preeclampsia, eclampsia, hypertension, pulmonary embolism, and pneumonia. If patient is stable, in antepartum period, we give the hydrolyzine nitrate of delivery. Then postpartum, in postpartum period, ACE inhibitor, ARB like angiotensin receptor blocker, ARNI, beta blocker, MRA. Then diuretic, consider the bromocriptine in postpartum cardiomyopathy if left ventricular ejection fraction is less than 35%. If patient is unstable, optimize preload, optimize oxygenation, inode drops, vasopressors, plan for urgent cesarean section. Then consider the mechanical circulatory support, transplant if further decision.
Dr. Naila, please expedite your...
Yes, ma'am.
Because we are having shortage of time already 4 o'clock. So
ma'am, this is the last slide, and it is I think it is an important slide in obstetric purpose. Like delivery consideration in women with severe heart failure or persistent hemodynamic instability, despite the treatment, urgent delivery by cesarean section should be considered, irrespective of gestational duration. For women with stable heart failure, vaginal delivery with epidural anesthesia is the preferred route. If vaginal delivery is pursued, instrumentation is often used to shorten the second stage of labor. Invasive hemodynamic monitoring by way of an intra-arterial line may be used to monitor the stability in labor and delivery. Epidural is the preferred anesthetic technique. Postpartum cardiorespiratory monitoring is often required in these patients is an intensive care unit or step-down setting. Thank you.
thank you, Naila.
Thank you, madam.
For your excellent presentation. We have one question from the Dr. Ambar Ashraf. in chat box. She asked, heart failure management needs heart failure clinic, where a multidisciplinary team approach should be predicted.
Ma'am, it should
And
be done.
nurses in paramedical should be trained and the proper cardiac rehabilitation programs should be followed. So it was her suggestion. I know your institute is running very well, and gynae department is giving services, excellent services. So how you manage this patient in your setup?
Ma'am, mostly patient come with they have a hidden valvular heart disease and they are present with symptoms in second or third trimester. This is a big missteps. You know, the patients are very young, like 16 and 17 in periphery, like when I work. And mostly the patient present with symptoms of like mitral stenosis or valvular heart disease in second or third trimester.
Okay. So, any question?
Madam? Hello.
जी सर.
हाँ डॉक्टर इमरान बताएं. हाँ.
Dr. Rajkumar, madam.
Yes.
Walaikum salam.
Are you asking any question, Dr.
No,
Rajkumar? I want to give.
I just want to comment that since we have also been studying on patients having peripartum cardiomyopathy and heart failure, the biggest challenge is despite of all the risk factors, we saw that there is hypertensive ladies, there are overage ladies, they have become pregnant and they are under, even one case we saw that was a girl of 12 years. She was pregnant and presented with the symptoms of heart failure, and then we worked out. Then we found that she was suffering from cardiomyopathy. But the biggest thing is that we miss a lot of patients because during pregnancy and last trimester, patient present with suffocation chart, we say, yeah, this is all because of the pregnancy. So this is the biggest challenge that rightly all the speakers said, that we must enhance the awareness among the people, especially the GPs, and our team should be strong enough to diagnose properly, and then we will be able to diagnose and treat accordingly. So this is my comment, that you have been working a lot on awareness, and it is proved now that females have around equal disease, cardiovascular diseases, especially the heart failure. So we must work on it, and we must enhance. And since you have collected from 7 to Sakha to Kashmir, people highlighting all those issues, so this will naturally work on. Thank you very much.
Yes, sir, you are very right, sir. And this happened in our institute also because of the huge. We have a number of patients. We haven't any. We able to counsel the patient. The cardiac patient need a counseling from a pre-pregnancy. You should plan the pregnancy before your when the cardiac fitness means the cardiologist suggests you, okay, you are now fit. But most of the patients, the thing is that most of the patients we see in the third trimester or second trimester with cardiac complication.
Okay, so we
Can
are
I
now
add?
moving to we are moving towards the presentation of Dr. Sabah Hussain. Our presentation is on preventing heart failure, the importance of early screening in women. So, Dr. Sabah, are you operate?
Yes, madam. I just wanted to confirm if you can hear me. If
yes.
You can hear me. So I'm sharing my screen first, right?
Dr. Sabah Hussain is from the National Institute of Cardiovascular Disease, NICVD from Karachi. He is working in imaging department.
So I hope you can see my screen too now.
Yes.
Okay, fine. So I wanted to say salam to all of you, and it has been a wonderful session. I really wanted to thank Dr. Khalida for, she is a wonderful teacher of mine from Civil. She just allowed me to share some of my things with you at this time. So I'm going to talk about preventing heart failure and the importance of early screening. in the females. Dr. Khalida has already introduced me. I'm working as an assistant professor at NICVT Karachi. So because of short of time, we're going to move forward. I have no specific disclosure related to this presentation. So as Dr. Shehbaz and Dr. Hunaina has wonderfully described it, I would briefly go into it, that yes, the heart failure is different in women and men. And it's different because the etiologies are different. As Dr. Hunaina told, that heart failure with preserved DF is more common in females than males. So the risk factor for such disease is definitely more important and common in females. So again, the research has already shown that females are much symptomatic than male counterparts. But on the other hand, they are also more ignored one, despite of being symptomatic. And this can ultimately end up with late diagnosis. Sorry. I'm really sorry. As the etiologies are different, definitely the screening protocol are tailored according to the different etiologies, and they are different in males and females. And I would say Dr. Shehbaz has already told about the socioeconomic factors. This is a very important barrier in Pakistan and countries like Pakistan. Many of our females, it's really hard for them to even go to the hospitals or to tell the doctor what actually they are suffering from. So this is kind of a real barrier in countries like us. Again, well, if I talk about the gender bias is not only a factor in Pakistan or underdeveloped country. Gender bias is everywhere. I have searched on many researches about it and found that all over the world, the medical care is kind of different. They are taken the different ways than male. And in this case, many of the females are actually ignored. Again, as Dr. Hunaina has told, and Dr. Shehbaz has also described it, that treatment the stages, they need the two essential drugs of heart failure, and similarly, they're more responsive to neprilysin when we compare them to the male. And the poorest thing in this that I would say, and has been taught by many of my co-presenter, that the females are underrepresented in the heart failure trials. They are the most underrepresented in the heart failure trials. This is where we are lacking the real data about how the female should be treated and what drugs are best for them and what are the real symptoms for it. So moving forward, the different etiologies we have already told about it just briefly. Yes, the heart preserved EF is more common in female, and the risk factor for this, they are more crucial, are hypertension, the diabetes, and dyslipidemia. So they should be strictly screened in females because they are important factors to end up in heart failure among females. Again, few heart failure, they are very specific to the females, like peripartum cardiomyopathy and Takotsubo cardiomyopathy. They are more common in the females, so they should be screened more vigilantly in the female. They are specific to the females. And then we talk about like certain gynecological and obstetric related issues. I'm sorry, can you still see? I'm sorry. So I got some, I believe, pop-up. So there are again certain gynecological and obstetric related issues like polycystic ovarian diseases, like I would say certain contraceptive pills and preeclampsia and eclampsia. They can also ultimately lead to heart failure in females. They are more specific to females. So training our gynae people, training our obstetric people is very important in preventing such failures. So again, raising concern these days is breast cancer. And to tell you, we are having a clinic here that is cardio-oncology clinic in our setup. And we are daily looking into certain patient, increasing number of patients, increasing number of female patients that are having the cancer. And because of the therapy, they are having reduced LV function. More importantly, the reduced LV systolic function. So this is a red flag these days. Ischemia, although completely less common in females, but again, it's an important cause, especially in the elderly females that are above 70 years of age, because the incidence of ischemia raised by about 3 times more than the male counterpart when they grow above the 70 years. So ischemia, yes, if the females are old, it's more important and should be screened, almost the similar ways the males are done. Certain genes can cause heart failure, but they are although more common in the male, like dilated cardiomyopathy, like hypertrophic cardiomyopathy, and a genetic testing are similar but not exactly the same, and they should again be a part of screening. So moving forward, I got some issue, I believe. Sorry, I'm trying to just move forward and it's not working that way.
Is that you started.
Thank you for advising me this. I'll read. First thing about the virtual advantages we are having because of it. Why don't we just let Dr. Khalida share this screen, because she also have my presentation. Dr. Khalida, can you do it for
Or
me,
you
please?
can do extempore, Sabha.
Okay.
I'm stopping my screen, and can you do? Can you give me this paper at this time?
You are sharing your presentation, Ruchi.
Thank you so much, Dr. Khalida. That's going to be a real help at this time, at least.
Sabha, you can go extempore.
Madam, I'm actually trying it.
Dr. Sabha, you stop sharing and Khalida can start it.
So this is actually by Dr. Khalida, I believe.
Yes.
Okay, Dr. Khalida, can you please go back? Okay, thank you. Thank you so much, Dr. Khalida. Yes. So we've already talked about the different etiologies. Can you please move to the next slide, Khalida? Thank you so much. Thank you so much. This is actually the same slide as Dr. Honana has told you. And as you can see, in majority of the trials, the women are very less. And most of the figures are between 20 to 25. So among the old data of heart failure, females are only represented in average by 20 to 25. And I feel it a little like, unfair with the female, maybe because I'm female myself, that generalizing the data results on a female is kind of little unfair. I consider it like this. So there should be more and more females involvement in the clinical trials. And this is not actually our data, this is the Western data. And even the women in the Western is less, I would consider more of the less female in our setup if we start doing such data. Dr. Khalida, can you move to the next slide, please? Madam, can you? Yes, thank you. Thank you so much. So why is it important to screen early? Just to tell you, and we all are familiar with cardiologists, that heart failure is one of the leading cause of mortality as well as among the females of all the ages. It's not, and the famous saying that is better than cure. And so the early detection means not only the early recognition of the disease itself, but early recognition of the risk factors that can ultimately end up with heart failure. Early recognition of such risk for the disease can move to an early therapy for prevention of such disease or for the reversing the heart failure. That really reduce the hospitalization, the complication caused by the heart failure, that will ultimately improve the quality of life that is worse as disease. They are taking care initially. Madam, can you please move to the next? Okay, so what is the difference in the etiology, or etiological screening of such females? As we have already talked about that female etiologies, so they should be screened in different ways than males, it's understood. But the variability, like different ages should have different screening program, this variability is more in female than it's compared to the male, because usually there is common reason for heart failure in males, but there is a variety of different reasons of heart failure in females. So there is different testing in different age groups. And especially again, emphasizing on the screening for the hypertension, diabetes, and dyslipidemia is very important in females when we compare it to the males. As has been already taught by my colleague before, that peripartum, madam, please, thank you. That peripartum cardiomyopathy screening is very important. Early echocardiography is very important because as Dr. Rajkumar has told, that many of such females are dyspneic and we just ignore them that as a part of pregnancy-related complication. But recently, a data from an institute that has been published in JACC and that has shown an asymptomatic pregnant patient. I just wanted to call it that an asymptomatic pregnant patient, at least 50% of such females were actually having LV systolic dysfunction. Now, see, I'm talking about asymptomatic. So there must be more if they are symptomatic. So this is kind of real high number, more higher than we have seen in the international data. So this has been published in the JACC and it's a wonderful data. You must see it. So it's very important to undergo to send such patient for an echocardiography for early evaluation. Again, for the postmenopausal female, as the schema increases, the risk of ischemia increases, the screening things are almost the same as that of the male, but they should be again should be screened in at least elderly, every woman that is above 40 with the symptoms. So thank you. Like we are in the webinar, so we, internets and artificial intelligence are now growing up, and artificial intelligence are enrooting in every part of our field, and we are also including this part in our studies too. So I find this wonderful article. I consider it to be a very nice picture in which they have summarized how such patients should be screened and how we can use artificial intelligence in screening such patients. And as you can see, if the patient is young, definitely the congenital and familial heart disease should be screened for. And AI-dependent ECG programs for such detections is a simple way, or I would say an easier way of detecting it earlier. Then when the reproductive age starts, definitely it's not important to screen such patient only during pregnancy or postpartum period, but just for at least 1 year, like after 3 months or 6 months and 12 months for gestational diabetes and diabetes. Otherwise, a yearly diabetes screening and obesity screening and dyslipidemia and hypertension, they should even be screened till the year follow-up after the pregnancy and delivery. This can again be done with the use of AI through the telehealth clinics and through the smartphone-based apps, just to screen out for the hypertension, just to tell them normal and what's normal. Screening. There are greater than 40 years of age, yes, the cardiac disease. And so there should be increased screening for the of hypertension. Again, in this phase 2, the smartphone-based apps can help us out for the early scanning of ischemia. So my few last slides, I would say, I believe are my second last slide. Dr. Khalida, can you move to the next slide, please? Thank you. Again, actually, I love the articles, and I was going through this article for this presentation purpose, and it's a wonderful article. It has been published in the Lancet in year 2022 by Susan, and they have told some great policies that we can implement. Even I believe we can also implement in our setup, just to screen so as I told you, to improve the health outcome or prevent heart failure in our females. So periodic monitoring should be started in every females after 18 years of age. Periodic monitoring for the blood pressure, for the dyslipidemias, for the sugar. Similarly, any patient that is going, any female that is going above 40 years or is postmenopausal, maybe a little early postmenopausal state, they should have an atherosclerotic cardiovascular risk scoring system, and they should be scored accordingly. Similarly, an early implementation of CAC scoring is important in the female, especially with at least intermediate risk of having coronary artery disease. As we already talked about, educating a gynecologist about cardiovascular risk in the females associated with their pregnancy, with their reproductive ages, and quick follow-ups, the more careful follow-ups are necessary. Educating them is very important because many of such females are actually young and they are not considering the symptoms being related to heart failure. They don't consider they can ever have a heart failure actually. Again, a simple behavior program should be started. There should be some funding agency that can, find out such programs, and there should be some tailored approaches for the female depending upon the prevalences of the particular risk. Madam, can you please move to the next slide? Can you switch to the next slide? Yes. So I would not take most of your time, so I'll rather end my slide just to give you a little takeaways. That heart failure is a leading cause of mortality and morbidity among women of all ages. And then again, women are different in etiologies. They have different outcomes. So whatever screening protocols are used, they should be different for the females and according to their etiologies and outcomes. Again, whatever protocol is used, the importance is of early screening. You should start early so to prevent it or to reverse it. This can ultimately end up with good outcome. And the most important, the last but not least, involvement in the research. There should be more female involved in the research so we can take more data and we know more better about their disease and their outcomes. So it's the crucial part of better address the issue in females. Madam, please. Yes. I would say thank you, and I may welcome.
Thank you, Dr. Subha.
Thank you, madam.
For this engaging discussion. And I have one comment for you on your presentation from Dr. Ali Anwar. The NICVD and other training centers should make the mandatory to educate promotion and prevention of heart disease by promoting healthy lifestyle like balanced diet, exercise, sound sleep, avoidance of stress and prayers. It is and the calming effect on the meditation. So, anyways, we are.
Madam, Madam, I just wanted to add a little one. You all are so welcome here, but you will find it wonderful here because we got very nice preventive program here. We are educating people about primary as well as secondary cares. We got special clinics for that. There is a special rehabilitation center, the smoking cessation centers. All of these are at NICVD. So I would say you will love it. I'll welcome all of you here.
Okay, so one of the comment also from the Sadaf Khan, just like correction among the pregnant patient screen, 96% has normal echo and 3.8% has abnormal echo. Out of the 3.8, half had LV systolic dysfunction. This was a comment from Sadaf Kiani. You want to say anything?
I'm sorry, madam. I didn't get it actually.
Actually, जो data share किया मैडम आपने डॉक्टर साहबा, वो जो स्टडी है उसमें ये थोड़ी सी वो शायद हमारी मिस इंटरप्रिटेशन हो गई है कि आपने बताया कि जो एसिम्प्टोमेटिक थे उनमें से 50% है LV systolic dysfunction. वो भी मैं देख रही थी स्टडी, तो उसमें ये था कि 96% of the pregnant females had normal echo and 3.8% had abnormal echoes. अब उस 3.8 में से जो उन्होंने डिजीज डिस्ट्रीब्यूशन किया उसमें half of them had LV systolic dysfunction और rest had valvular heart disease या other.
No, it's not like this. It's not like this, madam. It's not like this. It's not like this. If you go into the data detail, क्योंकि इसकी 3 publications हैं in JAC, और उसमें it's not like in total we found it. We found the patient that were actually asymptomatic. और उसमें से एसिम्टोमेटिक का हमने जो उसमें से एबनॉर्मल क्राइटेरिया था कि जिसमें से जो एबनॉर्मल डेटा हमारे पास आया था उसमें से हमने ये निकाले थे. It's not like the total population we have screened. I'm not talking about the total population that we have screened for the. I'm
नहीं तो asymptomatic
I misunderstood it previously.
I
मुझे
give
लगा
you
आप शायद कह रहे हैं कि 50% total were abnormal. लेकिन जब पढ़ा तो वो फिर सही समझ आ गया.
No. We have
No,
found
no,
out first what is the abnormal. No, we found out first what are the abnormal incidences of it, and among the abnormal incidences, among the patients that are actually having abnormal echos, it was incidence like this. But still, it's more higher. Even 3.8 is much higher than the international data.
Sabha, what I'm getting is are you telling us that you took all asymptomatic patients without knowing they have heart failure in the past or not, and they were all asymptomatic pregnant women, and you did echo and you found out 50% had LV dysfunction? This is what you are trying to tell us.
No. I'm sorry if it got it this way. It was actually the data says that most of the patients that were asymptomatic, they were evaluated in the clinic, the GoRed clinic, and even asymptomatic patient, the patient that are actually having cardiovascular disease, among them 50% were having at least mild LV dysfunction.
Okay, so Dr. Nawaz,
I'll share you the slide.
Give a comment on the presentation of Dr. Sabha Suhail. So Sabha?
Sorry?
Dr. Nawaz?
जी मैडम. Assalamu alaikum everybody.
Walaikum assalam.
So first of all, I congratulate my boss, ex-HOD, Professor Khalida Soomro. She is continuing this program for the awareness of the disease about the women. And here is our mentor, Professor Azhar Farooq is here. Sir, Assalamu alaikum, sir.
Walaikum assalam.
And my all esteemed guests and congratulate to all speakers. Excellent presentation by the Dr. Sabha and also other speakers and the Professor Shahbaz Qureshi. I like to add something. The cardiovascular diseases, actually, they are more morbidity and mortality is high in the women even before menopause. After menopause, only the atherosclerosis coronary artery incidence increase. But if you look below the menopause, the risk factors and the number of the cardiovascular disease are high, especially if you look the coronary arteries, they are the increased incidence of spontaneous coronary artery dissection, microvascular angina, cardiomyopathies, connective tissue disorder, and the valvular heart disease, they are high in the women in comparison to the men. So I think it's the time to screen these people's screening program should be done in order to detect these problems in the women, especially during the childbearing age group. क्योंकि हमने बहुत सारे पेशेंट देखे हैं जिनको पता ही नहीं होता 1-2 प्रेगनेंसी होते, either they diagnosed as a peripartum cardiomyopathy or they diagnosed with valvular heart disease, especially in rheumatic heart disease. इसमें तो ये भी देखा जाता है बहुत सारे rheumatic heart disease के पेशेंट MS के, they are treated with the anti-tuberculosis therapies. So I think every young girls whose age of the protected age, then that's all should be screened for the common cardiovascular diseases which produce the problems during the pregnancy and during delivery and after. So excellent talk from all the speakers. Thank you very much, Madam.
Thank you. So we are now moving towards the final presentation by Dr. Nusrat Tara. She will she will give overview of the heart failure and its management. Dr. Nusrat, we are sharing your.
हाँ करो, मेरा तो बैटरी बिल्कुल खत्म हो रही है. आई वंडर मैं बोल भी सकूंगी. अच्छा, प्लीज स्टार्ट शेयरिंग.
We are sharing your slide.
Okay. Thank you, and I'm very happy to see Professor Azhar Farooqi, Dr. Shahbaz Qureshi, 2 senior colleagues, and 2 or 3 junior panelists. I think whatever I wanted to say, most of it has already been said. there's very little for me to tell you anything. But anyway, heart failure is very common and the incidence is rising every second day. According to WHO estimate, in next decade or two, the 75% beds of any medical or cardiac units will be occupied by patients with heart failure. Slides to Khalida. And then, it has a high mortality both in men and women, and especially in women, since we are talking about heart failure in women. And women mostly have heart failure with preserved ejection fraction, but let me tell you, not all of them. At least half of the patients with heart failure presents with heart failure with preserved ejection fraction. The remaining one, reduced ejection fraction. And here, their prognosis is poor and they are more symptomatic as compared to their male counterparts. And women, as everyone has been saying, that they are underrepresented. So we really need to study further in order to find out the mechanisms and targeted therapies of heart failure. Next, please. Then in order to treat a disease, we have to go back to the pathophysiology or the causes. And the commonest causes you've already heard: hypertension, valvular heart disease, diabetes, and coronary artery. And since hypertension and diabetes, they are common in women and they both play an important role in genesis of ischemic heart disease. So in women, heart failure is contributed both by non-ischemic as well as ischemic factors. And other causes have been mentioned: peripartum cardiomyopathy, and viral infection, toxic effect of drugs, and the stress-induced cardiomyopathy that is reversible, and the stresses in women are mostly emotional. Next, please. That's why I very little, very small presentation because I'm very unwell. Now, in order to treat a patient, you must know the mechanism or the structure, anatomy, and physiology of the underlying heart. And for that, an echo is an excellent. It should be done in patients who present with unexplained shortness of breath. They are elderly, obese, and hypertensive, and they have other comorbidities like renal. Next, please, Khalida. Next, and then, we have to have a stepwise approach in diagnosis and treatment, pre-test assessment, that is signs, symptoms by history, comprehensive echo study, stress echo, as Dr. Shehbaz was saying, and invasive right heart catheter. Next, please, Khalida. Next slide, please. Yeah. So what do we have to look for in echo? Obviously, ejection fraction, which is 50 or more, LA volume, TR velocity, left ventricular hypertrophy, and elevated AEA ratio, which should be more than 2. Next, please, Khalida. Next slide, please. So yeah, the diagnosis is complex and challenging, so it is important for us to have stepwise assessment, and scoring is the key. And clinical assessment must be complemented with accurate echo study. Next, please. Next, Khalida. Yeah, and Dr. Shehbaz was mentioning, and I am a very strong advocate of microvascular disease in women. This is the case study which I did, I think, 20 years ago in Rawalpindi General Hospital. 48 years old mother of my house officer. She had been to various gastroenterologists, pulmonologists, and even neurologists. The symptoms same: neend nahi aata, dyspepsia, and shortness of breath. So finally, being fed up, she said, "Madam, aap dekhne." I heard the history and I was 95% convinced, rather 100%, that this is IHD leading to failure. I did echo and उसने मेरा हाथ पकड़ लिया, ये आप क्या कर रही हैं, मुझे तो पेट का मसला है. Anyway, what I found, big LV, I think ejection fraction was 30 or so. You can see pansystolic mitral regurgitation, and the most significant was, you can see this electrical alternance. That means that all the time she complained of dyspepsia or dyspnea, she was having inguinal attacks, and during each attack, a few cells do drop dead, and they are replaced by fibrous tissue, and that is why you have this electrical alternance. Then next, please, Khalida. And this is not only one patient. I had number of patients who had similar echo, and I always do carotid, and you can see intima to media ratio disturbed, and you can even see a small athyroma. So the moral of the story is that women present differently, and women have lower LV mass and greater LV contractility, and they even have faster resting heart rate. And for this reason, I think most of the treatment remains the same for both the genders, but beta blockers work well in these ladies. And another thing is that natriuretic peptide levels are higher in women because most of them are mostly obese. And then, as Dr. Sultana said about exercise, yeah, it's very true. Those ladies who have heart failure with reduced ejection fraction as compared to their male counterparts, they have more frequent evidence of episodes of dyspnea. They have difficulty in exercising, and they have edema, and they have seizure. So multidisciplinary would be ideal. And then, it is very sad, besides being underrepresented, there are less referrals for specialty care or diagnostic testing. Very few undergo procedures like revascularizations, ICDs, or resynchronization therapy. And I think this is what I can add a little bit, because everything else has been talked very elaborately by the previous speakers. Thank you so much.
Including Dr. Azad Faruqi luckily is with us. He has great experience in dealing with the men and women with heart failure. So I would like to have his concluding and the final comments on this subject. Professor Azad Faruqi,
Yes.
Are you hearing?
Yes, I am hearing you, and thank you, Dr. Khalida. This was a wonderful webinar, and the modern technology. I'm sitting 10,000 miles away from you, and gives me a chance to participate in. There is an advantage of getting a senior person like me, because I can give you a perspective on this whole issue in particular in Pakistan. But first of all, I want to go on record and tell you that I was pleasantly surprised and proud of the fact that the first speaker, Dr. Hunayn Shahab, is my youngest daughter-in-law. I like to think of her more as my daughter rather than daughter-in-law, because I have no daughters. My daughter-in-laws are sacred and near to me. So an excellent presentation by all speakers, but I remain proud of the fact that Hunaina is my daughter-in-law. I think there are a couple of things that I want to go on record. The world, when I started practicing cardiology more than half a century ago, so we're not talking of a decade or two or a few years. We're now talking of half a century ago. So things were totally, well, not totally, but a whole lot different. And there has been a lot of development in this area. And I think you'll be surprised as to what we did not know. We did not know about the heart failure with a preserved ejection fraction was not known. We had not even heard the concept of Takotsubu's myocarditis or cardiomyopathy was not even there. GoRed for women had not yet been launched. the whole world seems to have changed, but you'd be surprised as to how much we did know about heart failure, and in particular, heart failure in women. I published a paper in 1980. I had looked at all the reasons for admission to NICVD, and we were surprised that even though we should not be now, but at that time we were, that heart failure was the most common diagnosis for readmission to NICVD. And those were the times when we were exploring what is happening in Pakistan, what kind of diseases, and what should we do about them. So we were totally surprised, but now this is an established fact, and we know how common heart failure is. And another thing I mentioned about GoRed for women, I must acknowledge that one of my teachers, Dr. Nanette Wenger in Atlanta, under whom I studied, and then I was a colleague of hers at Emory University in Atlanta, was one of the pioneers and originators of the concept of GoRed for women. And Dr. Khalida Soomro invited her also many years ago in some webinar, and I invited her to Pakistan back in the 80s. She was a wonderful teacher, and I had the opportunity to host her. So moving on, I think one of the final things that I would like to add is, back then we realized how important this was. So we formed what I called at that time was Council on Heart Failure, COHF, cough, a synonym for Council on Heart Failure for heart failure. So unfortunately, it was there for a few years and then it got lost. But I think this is an ocean of knowledge that we are touching, and we have only touched the surface of it. There is so much that we need to learn and do. So I am so happy that Dr. Khalida took up the mantle of GoRed for women in Pakistan, and has now given us the opportunity to hear a lot on this. The subject is never ending. It is vast, but I enjoyed all the presentations. In particular, like to my pleasant surprise, seeing my daughter Hunana Shahab being the first speaker. Thank you very much, Dr. Khalida.
Thank you, sir. So as we come to the close of today's webinar, I would like to extend heartfelt thanks to all our distinguished speakers, our chairpersons, and wonderful audience for joining us and taking part in the and contacted us on the chat box. A special thanks you to Pakistan Cardiac Society, American Heart Association for organizing this important event. Heart failure is a subject and topic that needs more attention. I hope today's presentation has shed light on the importance of gender-specific care. Thank you again, once again. We hope to see you in the future events also. Stay safe, take care. Thank you. Oh, Dr. Ambar Ashraf is with us. I have seen her in the end. So, Dr. Ambar, can you give your...
Assalamualaikum, ma'am. कैसे हैं आप? खैरियत से हैं? Session, congratulations. Almost I have been through all the talks and it's the need of the day. Heart failure is not just a heart failure. ये पूरी एक दुनिया है और इस पे जब हम सब मिलके काम नहीं करेंगे, the pandemic is towards a rise and the quality of the life of the patient and especially in the women is deteriorating day by day. due to this lethal disease. Ma'am, salute to you, to all the chairperson and the panelists as well as the speakers. It's the need of the day और आप अपने ये जो presentations हैं इनको YouTube या किसी पे online करें ताकि general public, general practitioners, they come across. One thing which I want to add here that is very important is the heart failure management clinics. जहाँ पे हमें डॉक्टर्स की जरूरत नहीं है, छोटी नर्सेस को या पैरामेडिक्स को हम ट्रेन कर दें कि वो गुड ड्रग कंप्लायंस, how to look after their factors which aggravate the heart failure sign symptoms and the regular follow up. तो ये छोटे छोटे क्लिनिक्स अगर हम डेवलप कर लें अपने इवन ओपीडीज में, अपने प्राइवेट क्लिनिक्स में 2 लोगों को ट्रेन कर दें ताकि वो जो पेशेंट आए उसका डेली बॉडी वेट, इलेक्ट्रोलाइट्स, इनटेक आउटपुट उसे समझा दे, डाइट में क्या लेना है, ये 4-5 ड्रग्स बहुत इंपॉर्टेंट है, व्हाटएवर इट इज, तो वो कम से कम हमारा ये जो ट्रीटमेंट बर्डन और चीजें हैं ये कम हो जाएंगी। और इसमें जितना हम सब लोग मिल के एज अ टीम अप्रोच जाएंगे, ये जहाद है, मैं इससे ज्यादा इस पे कुछ नहीं कहूंगी। और सल्यूट टू यू मैम। एक अनदर इम्पोर्टेंट थिंग, द फ्लू वैक्सीन स्पेशली इन दिस सीजन टू ऑल द हार्ट फेलियर पेशेंट इज द नीड ऑफ द डे। तो कोशिश करें कि अपने अपने पेशेंट्स को जहां जहां पे भी हम सब हैं उन्हें फ्लू वैक्सीन करवा दें ताकि उनका चेस्ट इन्फेक्शन और रेट इस विंटर में कम रहे। और जो एग्रीवेटिंग फैक्टर्स में से एक अंडरलाइन चेस्ट इन्फेक्शंस या पोस्ट कोविड के बाद जो कॉम्प्लिकेशंस हैं, बाकी तमाम चीजों के साथ साथ डायबिटीज, हाइपरटेंशन, स्मोकिंग, pregnancy induced ischemic, whatever it is, thyrotoxic, endocrine disorders। लेकिन ये एक और इम्पोर्टेंट थिंग है जिससे हमारे 40 to 50% का रेट जो है वो कम हो जाता है। Congratulations to all of you. Thank you very much कि आपने मुझे ये opportunity दी। I love to be a part and parcel of your this all wonderful activities. It's a sadqa jariya and we are all together here. Thank you very much. और especially सर के फारूकी साहब के लिए बहुत सी दुआएं हैं, अल्लाह करे कि वो जल्दी से ठीक होके
जल्दी से हमारे
वापस पाकिस्तान आ जाए। जी, हमारे पाकिस्तान आ जाए ये कह रही हूँ। और शहबाज कुरैशी साहब की अभी भी मैं टॉक और वो सुन के आई, और अल्लाह ताला सबको बहुत जिंदगी सेहत के साथ रखे। और यंग प्रेजेंटर्स मैम जो आप ढूंढ ढूंढ के निकाल रही हैं, सुपर एंड द सुपर टॉपिक। I enjoy all the wonderful talks from our young presenters. Keep it up, जी।
डॉक्टर राजकुमार, आप कुछ बात करना चाहते हो?
डॉक्टर फारूकी के
Farooqi is, if you can see, Saab is at my clinic. He is inaugurating the PCS. Thank you very much, sir, for being all the time our guide and helpful. We learn a lot from you and still we are learning. Thank you very much, sir.
My pleasure and thank you. My pleasure and thank you.
Thank you, sir. So thank you, Dr. Sabah. Thank you, Nusrat, everybody. अजहर फारूकी साहब की मैं बहुत ज्यादा थैंकफुल हूँ कि वो अपना इतना प्रेशियस टाइम निकाल कर इस तबीयत के बावजूद हमारे साथ होते हैं, हमें गाइड करते हैं। और इससे ज्यादा मैं मेरे पास मैंने अप्रिशिएट करूँ। Every cardiologist in Pakistan.
So kind. I'm honored.
Thank you, sir.